My topic was RPLND, surgical aspects, morbidity and mortality, and then I'll be going over some of the ERAS details. My talk will focus on RPLNDs performed for metastatic or testicular cancer, because those comprise the vast majority of RPLNDs that we perform. In 2018 and 2019, we had 55 cases of RPLND, of which 80% were performed for testicular cancer. Now, of these 44 cases of testicular RPLNDs, vast majority, or around 60%, are performed for post-chemo residual masses in the retroperitoneum. The second most common indication is for relapses or masses that develop in the retroperitoneum during active surveillance for clinical stage 1 testicular cancer with normal tumor markers. Then we have had a few primary RPLNDs and one case of redo RPLND for an out-of-field recurrence. On the left, we see the most common templates for testicular RPLND, with the right unilateral, the left unilateral, and the full bilateral template. And here at VGH, the most common template we use is the full bilateral template in approximately 80% of cases. RPLND is still very much an open major abdominal operation. And in Vancouver, our full bilateral template spans from the renal hilum to the common iliac vessels, and from the right ureter to the left one. And we usually do RPLND by doing a split over the vena cava and aorta, and then we roll the lymph node packages posteriorly off from the cava and aorta. Lumbar arteries are usually spared as well as the IMA, but lumbar veins are usually ligated, depending on the situation, of course. And we also aim to do lumbar sympathetic nerve sparing by identifying at least 3 nerve tracts that come from behind the cava medially into the interior cable space to preserve antegrade ejaculation. At the end of the procedure, we usually always remove the conoval vein from the affected side also. In the literature, RPLNDs include additional procedures in approximately 20% of cases, of which nephrectomy is the most common one. Here we see a table of results from 4 of the most significant modern post-chemo RPLND series in the literature. There is one cohort from Cleveland, USA, another one from Scandinavia, the third one is from Germany, and the fourth one from Indiana, USA. All of these cohorts are retrospective, and the Cleveland and Scandinavia cohorts were done in a small volume centers, while the German and Indiana centers are what we can say high volume centers. When we look at operative time, it usually varies between 4.5 to 5 hours, and blood loss is on average from 350 mils to 1,000 mils. Length of stay at hospital varies between 4 days in Indiana to 8 days in Scandinavia, and complications from 4% to 30%. And we can see a fairly significant difference in the rate of complications between the small volume centers and the high volume centers. And this can also be seen if we look at major complications only, as there are reportedly 1.6% of major complications in Indiana, while there are 13% of complications in Scandinavia. Is there a difference in complication rate whether we do a unilateral or bilateral template in RPLND. This question is unclear. We have retrospective studies. If we look at the German and Scandinavian PC-RPLND cohorts, we can see that there tends to be a higher amount of complications with the bilateral template in both of these studies. But we also know that unilateral template is mostly used in post-chemo RPLND only in small volume disease, and therefore the operation itself is undoubtedly more easier. If we look at primary RPLNDs only, then according to a quite recent study from Heidenreich, it seems that there is no significant difference in the rate of complications. When we look at complication types, we see that the most common complication type is gastrointestinal one, with paralytic ileus being the most common of them all. The second and third most common complication is symptomatic lymphocele and VTE, while urinary injuries, postoperative hemorrhage, and neurological injuries are exceedingly rare. If we aggregate all these 4 studies together, we get a mortality rate for 30 days of 0.4%. In these studies, there were 5 reported deaths, and 2 of them were caused by pulmonary embolism. One was from aortoduodenal fistula, another one from Chylous ascites leading to peritonitis and sepsis, and one was from a postoperative hemorrhage from a vertebral resection site that was performed during the same RPLND. So postoperative paralytic ileus is a common complication after RPLND. The rate varies from 0.5 to 20% depending on the series and how they define the paralytic ileus. But usually the course is benign, and it's surprisingly rare to have postoperative SBO that would require reoperation. In this series, I found one case of colon necrosis caused by ligation of the IMA in an elderly gentleman. So while we try to preserve the IMA, most of these patients are young, and most likely ligating the IMA usually doesn't cause any significant problems for the patient. Postoperative symptomatic lymphoceles are quite common complications seen in from 0 to 9% of cases, and their course is usually benign. But Chylous ascites, which is a rarer complication seen in from 0 to 2% of cases, is a more morbid complication and potentially fatal. Chylous ascites is caused by the leakage of chyle from lymphatic injury, and the chyle itself is lymph fluid that contains high amounts of long-chain triglycerides, lipids, and proteins, and it drains from the small intestine to a structure or a lymphatic structure called cisterna chyli, which is located at the level of the renal hilum, in between and posterior to the cava in aorta. So the most common site of injury in Chylous ascites is at or below this area of cisterna chyli. Now, if significant chyle leak is left untreated, it can eventually lead to malnutrition, hypogammaglobulinemia, and immunosuppression, which down the road can cause peritonitis and sepsis. So how do we manage Chylous ascites? The way we treat chyle leak, or the experience we have with it, this is from a retrospective series on various different major abdominal and thoracic operations. And the main diagnostic tool is paracentesis, which also gives symptom relief to the patient. These patients also need nutritional support to replace fluid losses, vitamin deficiencies, and electrolyte imbalances. But the mainstay of treatment is dietary management. As we know that after having a fatty meal, the flow of chyle in the thoracic duct is significantly higher when we compare to patients who have a low-fat diet or are undergoing bowel rest. And in most of these cases with dietary management, we can reduce the flow of chyle so that the lymphatic injury can close spontaneously. And based on the literature, placing a patient on low-fat diet with medium-chain triglycerides has a success rate of approximately 75%. And if this method seems to be unsuccessful, then placing a patient on bowel rest and TPN has maybe a little bit more or a higher success rate in between 75 and 100% in the literature. Now, if the dietary measures fail, and then the second line option is to give patient somatostatin, and somatostatin decreases the flow in the thoracic duct and decreases the contents of triglycerides in the lymph itself. And the reported success rate with somatostatin is around 90%. Now, if the conservative methods fail, then the third and fourth option is radiologic interventions, either with percutaneous peritoneal venous shunt or lymphangiographic embolization. And the last option is surgery, which is undoubtedly a difficult procedure. What about pulmonary embolisms and bleeding complications? Pulmonary embolisms are fairly rare, but seen in approximately 0 to 3% of cases, and VT is overall in up to 4% of cases. Significant postoperative hemorrhages from the retroperitoneum requiring management are quite rare, seen in between 0 and 1% of cases. We do know that most of the bleeding complications usually happen during the first few days, while the risk of VTE is constant over a period of 4 weeks. And the EAU thromboprophylaxis guidelines do recommend mechanical and medical VT prophylaxis after RPLND all the way up to 4 weeks. Then what about pulmonary complications? As many of these patients have had bleomycin, our concern is that, as we know, that bleomycin may cause pulmonary toxicity. There might be increased amount of pulmonary complications. In the modern cohorts, however, the rate of major pulmonary complications is quite low, between 0 and 2%. Based on an earlier study, a significant risk factor for these complications is not unsurprisingly the thoracoabdominal approach. There is a fairly recent, still retrospective study from the Indiana looking into pulmonary morbidity between patients who received bleomycin and those who did not. And in this study, they did not notice any significant difference in pulmonary morbidity when the patients were treated with restrictive perioperative fluid and supplemental oxygen therapy. We'll be going over bleomycin more in Kelly's talk. So what are the results from PCR-RPLND at VGH before the ERAS era? This data is retrospective and obtained from Accuro, so be wary. But nevertheless, on the left, we can see the results from VGH 2018-2019, and on the right, we see the results from the four aforementioned studies. We had 27 cases of RPLND for post-chemo setting and approximately 14 cases per year. The median age of the patient was 31 years, and most of our tumors were in between the size of 2 and 5 centimeters. Estimated blood loss, the average and the median was in between 500 and 600 ml. and the hospitalization time median was 5 days. So we're doing pretty good when we compare it to the results from literature. And in complications as well, the rates are quite low, 11%. We had 3 patients with complications. One had a pulmonary embolism, one had an SBO requiring a reoperation, and a third patient had a renal infarction. Sorry. So while we're doing fairly well, there's always room for improvement. And how does ERAS and RPLND work together? The origins of ERAS, or enhanced recovery after surgery, protocol is from studies made by the Scandinavian group in the late 1990s and 2000. And the original idea is that to better control post-operative physiology and surgical stress response, and therefore morbidity, the perioperative care should be arranged in a multimodal structured protocol. And based on these studies, ERAS Society was founded in 2009, and ERAS Society has since published several ERAS guidelines on different surgical fields. But for RPLND, there exists no ERAS protocols and no published studies so far. So what is the best level evidence for ERAS protocol? The first systematic review and meta-analysis of ERAS protocol in colorectal surgery came out in 2010, and this comprised 6 RCTs with a total of 450 patients. And in this study, the clear finding was, a significant finding was that ERAS protocol reduced length of stay and complications, while there was no change in readmissions to the hospital or mortality. There's also another fairly recent meta-analysis from 2018, which looked into other major abdominal operations other than colorectal surgery. And this systematic review and meta-analysis had 14 RCTs with a total of 1,300 patients. Most of the RCTs were done on upper GI surgery, but there was also 3 studies on urological surgery. And in this review, their result was that on the RCT studies, the ERAS reduced length of stay, time to passage of gas, and the total hospital costs per patient. No significant change were seen in complications and readmissions. So we have high-level evidence on ERAS protocol that it works and seems to at least shorten the length of stay and most likely hospital costs, as well as it seems that complication rates or readmissions do not increase. So the VGH ERAS work group, led by Alan So and Kelly Mason, with the help of Amy Myring, Julie Nakahara, Tara Smith, and Kulvinder Sanja, developed ERAS RPLND protocol last year, and this was implemented in December 2019. Here we see the summary of the components of ERAS RPLND protocol, and our protocol includes preoperatively a new ERAS RPLND booklet, patient information booklet for the patients. Preoperatively, we also have reduced fasting duration, carbohydrate loading with CHO drink drank by the patient in the morning before the surgery. We also don't use any bowel preps as before, and we have antibiotic prophylaxis and pre-warming included in the protocol. Then intra and post-operatively, we have VTE prophylaxis starting from heparin and SCDs intraoperatively to enoxaparin 4 weeks post-operatively. Patients will undergo goal-directed fluid therapy, multimodal anti-emetic protocol, and pain management with an epidural. During the operation, we'll be using active warming to keep the temperature above 36. will do antibiotic redosing in cases of ORs lasting more than 4 hours, and EBL if the EBL is more than 1.5 liters. Postoperatively, patients will do come and they will be placed on early low-fat diet starting POD1 and early ambulation. And we will also be removing Foley catheters on POD2, even though the epidural is in situ. Surgically, there are not a lot of differences in the technique. We'll be still using a lot of clips to contain the lymphatic lymph leaks, and we try not to place any prophylactic grains or NGTs to the patients. Thank you. I think now is a good time for discussion, or if you want to proceed with the components of the ERAS RPLND in more detail with Julie and Amy.
Tuomas, it looks identical to the cystectomy ERAS, except for a couple of components.
Yeah. So, Julie and Amy, do you want to go over the components in more detail?
Are you able to hear us now?
Yes.
Okay, excellent. I'm so sorry for the hiccup at the start. I think we just had to switch our audio. So what's a virtual rounds without a
So now we're going to move to
so thank you so much for having us here. I'm Amy. This is Julie. We're the two ERAS coordinators at VGH, and you obviously guys know Kelly. She's anesthesiologist and regional medical director for quality and safety. Okay, so we've started our screen share. You guys can see our screens. Let us know if you guys have any questions or you can't see what we're presenting. We're going to go over the ERAS RPLND. We'll use a mix of Menti and then also PowerPoint slides. Julie and I will go over the first bit of it, and then Kelly will take over, and we have a survey monkey at the end for feedback.
Perhaps about our audio now.
Yes.
Okay, so here's a brief outline. I won't go too much into the details. We'll change the pace a bit here. We'll start with Menti. If anybody can log on to menti.com, I will share the screen for it here. This is our first question. 586356 is the code. So what fun things are people doing at home? It's a word cloud, so if you can type in, we can start to see what people are doing to entertain themselves.
I think you got to give us a moment.
A moment? Okay. No problem. Excellent.
So we've got 6 people responded. A coffee infusion, I like that one.
Zoom, excellent. Okay, I was hoping for some Tiger King, but clearly you guys are watching something a bit more educational than that. Okay, we'll just move along just to be cognizant of time here. So we'll start off with these lovely young traps. So patient's surgical journey starts by seeing these lovely traps and their colleagues. So when the patients go to the surgeon's office, they receive this 80-page booklet. It's got things about what the surgery will entail, what to expect every day after postoperatively, and some information about what to expect when they go home. So the patients are expected to read these booklets before their pre-admission clinic appointment, ideally. And then once they're at the pre-admission clinic, the nurses go over some of the information that's in there. And then the patients are expected to bring the booklet to the hospital and then review or refer to it as needed. So why does ERAS focus so much on preoperative education? Well, it's because there's studies out there saying that it decreases patients' anxiety and fears, And then ultimately it decreases the complications and the length of stays. So we put our gastrectomy ERAS booklet through this volunteer group. There are people out in the community that review our booklets and pamphlets for us, and these are the direct quotes that we received from them. The gastrectomy and the RPLND booklets are fairly similar in style. So it's nice to know this one lady kept it for 8 months after her surgery and still referring to it. So I think there are many benefits to having this 80-page booklet. So Menti question number 2 here. Oh.
You can see the code at the top. It's still the same if you guys need to re-enter, or you can always refresh your page if it's not prompting up with the right question.
So if Mr. Peter So is going for surgery, what are the carbohydrate loading guidelines for surgical patients? NPO at midnight, NPO 12 hours prior to surgery, NPO 3 hours prior to surgery. There's no benefits to carbohydrate load. Okay, that's fantastic. So it looks like you guys are paying attention to Tuomas's slides earlier. So that's great.
Thank you.
So here's a list of the benefits of carbohydrate loading here. Patients are less hangry, minimizing insulin resistance postoperatively, and decreasing catabolism are one of the main ones here. Patients are instructed to have some juice in the morning prior to coming to the hospital, or they can purchase this pre-covery. It's 50 grams of complex carbohydrate, and so it stays in the body system a little bit longer. So they seem to think that it helps a little bit more with insulin resistance than just simple carbohydrates. Moving on to the screenshot of the pre-printed order here in the carbohydrate loading instructions. Essentially, you know, it's contraindicated in the patients with bowel obstruction, gastroparesis, or insulin-dependent diabetics. But aside from anybody else, it's highly recommended to have a carbohydrate load just to minimize the fasting times. And then our ask is that when patients are admitted prior to surgery, if you can avoid writing NPO at midnight, and then just either refer to the pre-op orders, or if you can just write drink 250 mils of clear juice 3 hours prior to surgery, and then the nurses on the unit can try and orchestrate that. Here's a quick run chart from December to March with the carbohydrate loading compliance. The red line is the 80% goal here. So in December, 2 out of the 3 patients carbohydrate loaded. February was a good month with 2 out of 2 patients, and so on and so forth. The patients who didn't carb load was because they forgot in the morning and just had water, or they were admitted previously and was written NPO at midnight. So just another reminder to let's minimize fasting times. So when people hear ERAS, a lot of people are like, oh, is this, you know, the gum chewing thing? And then we say yes, but just gum chewing alone is low evidence for ileus reduction, but it is high evidence if it is used in a multimodal approach. So in conjunction with limiting opioids, an MIS technique, which is not always possible, but it's in conjunction. So, and then if you can eliminate just prophylactic NG insertions, then there is high evidence for gum chewing to reduce ileus.
Great. Okay, so we're going to switch gears and go back to Menti. We have 2 questions for you on post-op nutrition. Okay, so the first question is, when should Mr. Peter So start having a solid diet if he's having RPLND surgery? So multiple choice. Good. Looks like we got 8 responses, 9 responses. Okay, excellent. So majority are saying pod 1, so that's right. That's according to the PPO. And then one more question on Menti. This one is a word cloud. So you can type in your answer here. And we're just switching to the next one. Oh, one more back. Here we go. So when is early feeding contraindicated? So this, you can type in your answer. We have a lot of questions around this across groups, across surgical specialties. So we just kind of want to get your guys' thoughts.
So Amy, on the app, there's this guy dancing around on a bunch of loaves of bread. Is that Matt Ho? It looks a lot like Matt Ho.
How'd you know? Is he into Olive Garden breadsticks? Okay, so some good answers. Ileus, bowel obstruction, decreased LOC, yeah. Okay, I think we probably ran out of time on that one, so that's good to know. So really, I think our main thing is for that point, it's different across surgical specialty, or even you're going to get a different answer, I think, from surgeon to surgeon within the same group. Our main takeaway is that if you know there is a contraindication, just you can modify the diet order on the PPO and then just write the rationale for why the diet's contraindicated. As you know, we're a teaching hospital, so communication is really clear. You'll have, you know, a different resident the same day coming back that might not know. You'll have different nursing staff, different dietitians coming in. So I think it's really clear just to write the contraindication as to why you can't have the designated PPO diet if you have to stray. So this, back to our PowerPoint, this just goes over some high-level evidence as why early post-op nutrition is important. So you can see a delay in resumption of normal oral diet after major surgery is associated with increased infectious complications and delayed recovery. Also, to reach the protein and energy requirements for surgical patients, we often supplement with Boost. So that's why you'll see Boost 1.5 in the Tetra Pak, that's just the carton. Or you'll see for RPLND, it's a low-fat one, so it's Boost Fruit, which is just a clear fluid form of Boost. I want you guys to know that the diets for ERAS are created in collaboration, obviously, with the whole team. The dietitians have spent a lot of time. They usually benchmark with other sites within BC or across Canada. For RPLND, I think they did benchmark with Hamilton Health Sciences, so it is made with some thought. And then the diets are embedded in the nursing care pathway, so the nurses know when to advance and they're prompted. All right. Okay, so we might just move. I don't know if you guys can see. I'm just going to drag our text box over here. So this is a clear fluid tray, just to give you an idea of the nutrient content per tray. It was very mind-blowing to us. There's only 200 calories per tray and 1.3 grams of protein in each tray. So I think if you do the math, I don't think that's going to be anywhere near the protein and caloric requirements for surgical patients, let alone somebody who hasn't had surgery. So I guess just to keep in mind, be mindful of when you are keeping a patient on clear fluid, there's a rationale. All right, so this just is a snapshot of the PPO. So post-op-day-1, low-fat diet with Boost fruit beverage. Again, if you're going to if the patient needs to stray from the diet due to, you know, an ileus or decreased LOC, like you guys mentioned, then you can cross out the order on the PPO and then just write an alternative diet with the rationale, so the whole team is aware. The dietitians also provide low-fat diet education prior to discharge, and they review the information that's in the booklet with the patient. So just so you guys know, they do get some teaching as well.
Amy, can I ask a question?
Yeah, for sure.
Low-fat diet, sort of prophylactic low-fat diet. What is there evidence, or is it just sort of?
Yeah, I think it's mixed. It's mixed is what the literature said. I think when we are benchmarking with other hospitals, because there's not a lot of evidence, there's evidence that's kind of to support either way. Most hospitals were actually on the even conservative side. So they were limiting patients to 10 grams or 20 grams a day of fat. Here, our low-fat diets that the kitchen puts out are for 50 grams a day. So we took a little bit more of a looser approach, but it still is considered low fat. And I think as Tuomas kind of went over it, yeah, it's preventative to prevent Chylous ascites. So I guess we will see. We'll see how it goes with the complications for our patient population.
Peter.
Well, we don't
Peter.
have a high rate of ascites, and so it's gonna be hard. It's we're not gonna have much to compare to. I just my only reference is as a resident and fellow, we fed them normally, and of course we saw Chylous ascites every now and then. So it doesn't inform anything, but I've always just wondered what the data is.
Yeah.
So
for sure.
Peter. Yeah. So the data on low-fat diets and Chylous ascites is on the management of Chylous ascites, and that's level 3 evidence. I didn't find any studies per se on prophylactic low-fat diets to prevent Chylous ascites, but I think there is a rationale there, physiology, because we know that the low-fat diet decreases the flow of the chyle, and it's easy and cheap. So
there is and there isn't, right? If we don't have a problem, why torture patients with low-fat diet, right? So there is a downside to it, and the one other, the general point in the discussion about Chylous ascites is I've had 2 patients with ascites over the last couple of years, and neither of them was obviously Chylous, and both of them ended up with a procedure by radiology where they inject a lymph node in the groin and see where the leak is. One of them was a distal leak off the common iliac vessels in the pelvis, so it had nothing to do with chyle and nothing to do with the GI tract. And so I just think it's an unknown. I'm not saying there's anything wrong with it. It's an unknown, and there is a downside to it.
Yeah.
I think just from my perspective, that when we're looking at ERAS, the reason why we do ERAS is to compile multiple different components in which we will never get a level 1 trial to assess. And I agree with you, though, we may not get the answer for Chylous ascites, but it's just something that I was actually strongly recommending, just to at least do something to minimize the risk of Chylous ascites. It's very low, but when it does happen, it really significantly interferes with the quality of life, and as Tuomas mentioned, can even be life-threatening. So I agree, it's not the most comforting measure, but I mean, it's only for a few weeks post-operatively. So I think it's a small price for potential big gain. But again, that's why we're doing it in an ERAS type of a situation, in which we'll never actually do a clinical trial to measure if it's actually proving to be beneficial or not.
Mm-hmm.
Yeah, no, I don't disagree. I'm just being devil's advocate.
No, it's all good discussion. Okay, we'll keep moving along because I feel bad here for Kelly. We'll try to sort of wrap this one up. This is just high level on early activity immobilization. You guys obviously don't need to know the benefits. You know the benefits of why patients should be moving early on. They're listed there. Our goal for the RPLND patient population is walking in the hallway ×2 on pod 1 and 2. As you guys know, these patients are young. They're like 30s, 20s, and 30s for majority. So they've been reaching that goal. There hasn't been much of an issue. And feedback from the physios on the unit is saying that since we've standardized it, it's allowed them to get up actually a lot more independently and earlier. So that's a benefit at least. That's the order on the PPO, activity progression as per clinical pathway. That's in our pathway, the nursing pathway. So each day we have functional mobility section, and that prompts the nurses each day to kind of be aware of the goals. That's our data showing adherence to patients being able to walk in the hallway from December to March. We dipped a bit in March, not for the physio's lack of trying to get the patients up. The patients were just quite dizzy and hypotensive, so they're unable to do the 2 walks. Okay, we're gonna flip back to the Menti. Okay, so this is a word cloud. We just want to get your guys' ideas around this. So what factors contribute to postoperative urinary retention? Type in your answer or your thoughts. Nice. Okay, meds, epidural, opioids, pain. All right. Okay, and we're going to do one more question around urinary retention and early catheter removal. What are the benefits of early catheter removal? This one is a multiple choice. Okay, so benefits of all of the above. We have one person choosing that. Patient comfort, 2. Okay, decreased risk of UTI. Okay, good. Okay, we'll switch back. I think Tuomas is going to briefly talk about this slide on early Foley, early removal of Foley catheter and epidural analgesia.
Yeah, thanks, Amy. So shortly, this was a paper from 2019. It's a German study where they did a prospective collection of data from patients who were started on ERAS protocol and early removal of Foley catheter, and then they compared this group of 114 patients to a historical control group before the ERAS era. And then they looked at the results and saw that postoperative urinary retention, while it was more common in the early removal group, the rate of postoperative catheter-associated UTI was significantly higher in the control group. So I guess I think the main talk or the point here is that for most patients, having the catheter on for several days is unnecessary and increases the risk of UTI. So I think it's feasible to remove the Foley catheter, especially in a patient population that is young, as the RPLND population. Thanks.
Okay, thank you, Tuomas. Yeah.
That's a crazy high rate of UTI. Like they define it by a positive dipstick or something.
Yeah, I agree. This is a colorectal surgery population, and the age of the patients were about 60
Okay.
on average.
Okay. Okay, so this is just reiterating. Duration of catheterization is directly related to UTI. Catheterization may limit mobilization. This just highlights that on the pathway for nursing, it prompts them on pod 1 nights to take out the catheter on pod 2 morning. So just so that you know, it is prompted, and that is our order. And then this is actually some of the data from December to March. So this is on adherence to taking the Foley catheter out on pod 2. We have a dip in February. That's because there was a direct order to leave the Foley catheter in until the epidural is removed. But another piece of information, out of all the patients where the Foley was removed on pod 2, none of them retained. So they all have their epidurals still running. And as you know, the epidurals are weaned and discontinued on day 3. So to the point that, yeah, they still have epidurals running when their Foleys are taken out, but they're not retaining. That speaks probably to the fact that it's multiple factors that cause postoperative urinary retention. You can have a patient who doesn't have a Foley or an epidural and they still retain because they're maybe an 80-year-old male who has BPH and on alpha or beta blockers. So there's multiple factors. It seems like because this population is young, they don't have the history of BPH. It seems so far that it's working. There's obviously going to be a gray zone, but just to show you a bit of local data.
So this is just to summarize. Essentially, we wanted to say you guys are doing a fantastic job. The PPOs are being used, the nurses are using the pathways, and patients are receiving the booklet. So keep up the great work. Take-home message.
Oh, one more take-home.
Just summarizing our take-home message here. Okay, so Kelly will.
All right.
All right, so 10 minutes to go through everything you want to know about anesthetic considerations. I want to sort of highlight 6 aspects of it, some of which have already been talked about a little bit already, so I'll sort of run through this as quickly as possible here. I think we've hammered home the issues about the NPO status, the benefits of carbohydrate loading. why we're doing it. Again, clear evidence that with both water and complex carbohydrates, they're empty from the stomach relatively rapidly. So this is why this 2 to 3 hours before surgery is entirely safe and beneficial to patients. Sorry. All right. And this is not new. This has been well established in our guidelines on anesthesia since 2014 with regard to clear fluids and solids as well too. The other most important aspect of management of these patients is optimization of pain management. This is key. And basically, when we talk about multimodal analgesia, it's talking about using more than one pain modality. I'm trying to talk too fast here. And we really want to get effective analgesia and minimize the opioid side effects. And so for us, it's asking all of my partners to give at least 2 non-opioid modalities. And that's relatively easy to do because every single patient gets loaded with acetaminophen preoperatively and then throughout the perioperative course. And then we choose a regional technique. And the question is what regional technique to use. Certainly thoracic epidurals have been the mainstay of open procedures for many years. I wish I could say that they're perfect, but occasionally they do fail, and occasionally they do give patchy analgesia. They certainly can be used for both open and MIS, but now with the shorter lengths of stays with MIS procedures, the real benefits of using them is much less and may actually delay the patient getting out of hospital. So really we're trying to save them for the open procedures. If you're going to use them, again, we're trying to sort of give the minimum amount of local anesthetics and to add some narcotics with it to minimize problems with hypotension. There are some different options out there that most of you are familiar with. As I said, certainly in the radical cystectomies, we were involved in a trial with using rectus sheath blocks. The key with this sort of slide is just to remember that with rectus sheath blocks, it's a fairly narrow area of analgesia that's being covered, whereas with the epidural, much wider area, and it covers the visceral pain significantly. Some of you may be also familiar with the concept of TAP blocks or transverse abdominal blocks as well too, which is useful for some of the procedures that are below the umbilicus. And again, I don't really care who puts in the local anesthetics as long as you put it in correctly. So certainly with the rectus sheath blocks, they can be done under direct vision. They can be done ultrasoundly. Likewise, the TAP blocks can be done with an ultrasound, or if you're doing a laparoscopic procedures, as it's the muscle that is closest to the peritoneal cavity, you can actually do it under direct laparoscopic guidance, seeing where your needle is and then seeing where the bulge is. So those are all options. For any reason why you had a patient who you couldn't get an epidural into, one of the other options is to use intravenous lidocaine. It's been shown to decrease pain requirements. It's an anti-inflammatory. It also decreases the risk of ileus. It can be used, they're typically most commonly used intraoperatively, but it can be continued in the PACU, and it can also be continued on the ward for a couple of days as well too. The other key is appropriate use of fluids. We know that if we give insufficient fluids, you end up with some degree of a sort of ischemia and decreased perfusion to the organs. But if you overhydrate patients, again, you end up with anemia and dysfunction. So how do you end up getting into this sort of sweet spot here? So the whole concept of goal-directed therapy is trying to optimize cardiac output and oxygen delivery to the tissues. And so looking sort of at the Starling curve and looking at your stroke volume variation, if you're volume responsive, you see more stroke volume variation. And as you give a fluid bolus, variation decreases. Once you get up to the top of the curve, giving more fluids does not improve your cardiac output. There's two major monitors, the esophageal Doppler, which has been sort of embraced in the UK, but less so in North America. And more in North America, and certainly at VGH, we're looking at arterial waveform analysis for doing goal-directed therapy. Again, it's probably not required in every single patient. We actually ended up sort of having a working group when we first started doing this in colorectal surgery, and was felt that we should be really using it in more of the open procedures, the longer procedures, patients of higher risk who are older, where the expected blood loss is greater, and certainly in the very frail or the obese patients as well. And sort of came up with some sort of basic sort of guidelines of what we should be doing as a maintenance infusion intraoperatively. And then if the patient was hypovolemic, giving small boluses of fluid. So we're talking about 3 mils per kilo, so about 250 mils of a bolus if you think the patient's fluid responsive, and then reassessing the situation. There's no evidence to suggest that colloid should be given over crystalloid. And then reassessing what your stroke volume variation is. 2 years ago, this big trial came out, the RELIEF trial, about this whole sort of concept of restrictive versus liberal therapy. Certainly when we reviewed our literature, we were probably most of the time giving more fluids than what we required. This ended up coming out sort of suggesting that doing a restrictive component resulted in a slightly increased risk of acute kidney injury. So the question is, where's that sweet spot? So we went back and kind of looked at the guidelines, and the Enhanced Recovery Canada suggested that probably in the range of 6 to 8 mils per kilo per hour with a sort of positive balance of 1 to 2 liters would probably be adequate for most. But if you're doing goal-directed therapy, you may be able to fine-tune that number down a little bit more because you're actually driving your therapy based on your monitor. It's not only important about how much fluid you give, but what type of fluid. So again, there's great differences with regard to their chloride content and their pH. We talk about normal saline, but I ask you how much is actually in a bag of normal saline. It's 9 grams of sodium, and 9 grams of sodium is equal to about 20 of your lunchtime bags of potato chips. So you can understand that patients probably don't feel great with that 1 liter bolus of normal saline. So again, saline results in hyperkalemic acidosis, which can decrease cardiac contractility, decrease renal perfusion. And again, there's been a variety of studies, some of them retrospective, looking at giving normal saline versus plasma light, and certainly the evidence is more towards using a balanced solution. Again, a variety of studies have been published showing less kidney injuries in patients coming in through Emerge, ICU patients as well. So we've really switched in the OR to plasma light, and I think on the ward, you're using more Ringer's lactate. Controlling postoperative nausea and vomiting is important if you want to be feeding the patients. Depending on risk factors, their patient's risk can be as low as 10%, but in some patients, the risk of postoperative nausea and vomiting can be as high as 80%. Good studies to show that if you intervene and give a prophylactic antiemetic, you can significantly reduce the risk of postoperative nausea and vomiting back to the baseline, which in the most surgical patients, the risk of postoperative nausea and vomiting in the first 24 hours is 30%. We don't really care which agents you use, as long as you use an agent. So this is what we end up sort of tracking, seeing what the risk factor is and how many agents that we're giving in the OR. Preventing hypothermia is also important. We're talking about sort of mild hypothermia in the range of 34 to 36 degrees. Again, very clear, strong evidence suggests that as your temperature drops, your risk of surgical site infection increases because your leukocytes and neutrophils don't work as well. You get vasoconstriction, obviously increased risk of bleeding, which results in a higher rate of transfusion. And in patients with underlying cardiovascular disease, there's an increased risk of cardiac morbidity because of hypertension, shivering, and increased oxygen consumption. Our response to temperature is tightly regulated, normally within 0.2 of a degrees, and you bring in your protective mechanisms. But anesthesia basically impairs this response, so we have to take some ownership that now within 4 degrees, these protective mechanisms don't kick in. So that's why hypothermia is more common in the OR setting. The majority of the heat is in your core, 2/3 in the core and 1/3 in the periphery. But again, anesthesia results in vasodilatation, which then results in a shift of the temperature and increased heat loss. So this is the whole sort of concept of pre-warming patients. Patients that aren't pre-warmed, the temperature drops more and it takes longer for them to get back to normal. But if you pre-warm the periphery, they don't drop as far and they remain normal thermic for most of the case. I want to just touch on the aspect of importance of glycemic control. Certainly with our patient population, up to 15% of our patients are diabetic. We've started with the ERAS protocol testing hemoglobin A1Cs and have found that about 5.1% of patients have undiagnosed diabetes and about 11% are pre-diabetic. Many of the non-diabetic patients develop hyperglycemia. These are the stats looking at the radical cystectomies. So 40% of them had moderate, these are non-diabetics, had moderate hyperglycemia postoperatively, and a quarter had significant hyperglycemia. And this is again because of the surgical stress results in metabolism and insulin resistance. So again, this is the importance of carbohydrate loading. A little bit just from the stats of the radical cystectomies, you can see that the non-diabetic patients who had significant hyperglycemia actually had increased incidence of complications, and the incidence of complications in the diabetic patients was incredibly high. Again, small sort of numbers here, and this is, we actually realized that we weren't putting in standard sliding scale for the non-diabetics at that point in time, so we corrected that problem, so hopefully our numbers are down now. Bleomycin, again, is used in most of these patients coming for this procedures. And as I said, the concern is this bleomycin-induced pneumonitis and pulmonary fibrosis. Patients that are increased risk of it are the older patients, those that smoke and have decreased renal function. As I said, this is more in the patients who are getting it from non-Hodgkin's lymphoma than for this procedure. There is some advice that is given out to patients with regard to it, kind of generic and avoiding high concentrations of oxygen, but not really defining it. So maybe scuba diving is not the best thing to do, and certainly during anesthesia, probably keeping it below 40%. And if anybody wants a reference about this patient information, I've given it there. I think the big thing with ERAS is understanding that it's a package, it's a variety of components, and again, this is a good study of over 900 patients undergoing colorectal procedures that show that with increased adherence to the various components of it, you get a dose relationship. So your symptoms, your 30-day mortality, and your readmissions decrease as you more adhere to the protocol, with it sort of tailing off around 80%. So again, I've just kind of brought up some of the numbers for radical cystectomies. You can see that with the pre and the intraoperatively, we were doing reasonably well, but it's those post-operative elements that we often struggle with. We actually broke it down for the radical cystectomies, looking at this. So our pre-ERAS data, fairly high incidence of complications. Post-ERAS, we dropped it, but we dropped it by 50% in the patients that had over 75% adherence to our pathway. So I think it just, as I said, that ERAS does work. It does decrease morbidity. We've shown it in a variety of different patient populations. And we're hoping to roll it out to nephrectomy as well. And I think we're almost out of time.
Yeah, yeah. You can use the QR code to fill out a survey if you want, or you can go to the link. But yeah, thank you so much for having us, and sorry for the technical glitch at the start.
Yeah, thanks, Amy and Julie and Kelly, and sorry, Kelly, for you to have the rush through your presentation.